All right. Good day to all of you and welcome to this TBS webinar. I am Antoine Nico from Medimaps. I am very pleased to see all of you connected today. This webinar will introduce or reintroduce you to the Trabecular Bone Score assessment, which is performed by DEXA machine at the same time as BMD measurement. This report aims to identify more patients at risk of fracture, fine-tune therapy decision, and improve patient management. This webinar is being recorded and will be sent to you after its end. It will also be available on medimapsgroup.com and our YouTube channel. For this webinar, I have the pleasure to present you to the two speakers of the day, Dr. Luis Del Rio, who is nuclear medicine specialist. Dr. Del Rio is head of the Serum Densitometry Working Group in Spain and scientific director of CETIR Medical Group. He will present the advantages of using TBS in the clinical management of osteoporosis. Then we'll have Dr. Thomas Paul, who is endocrinologist. Professor Paul practices at the Department of Endocrinology, Diabetes, and Metabolism at CMC Vellore in India. He's also a member of the Endocrine Society of India and Secretary of the Indian Society of Bone and Mineral Research. He will share his Trabecular Bone Score experience from CMC Vellore. Before I let Dr. Del Rio start his presentation, I invite you to write all your questions that may rise during this in the Q&A section. At the end of the presentations, I will ask them to our two speakers. So now, Dr. Del Rio, I would invite you to share your video and share your presentation so we can...
I care to share. Okay.
Excellent.
Okay, it's possible that you see my presentation?
We see your screen. Yes, thank you, doctor.
Okay, I can start?
Yes, please.
Oh, wonderful. Fine. I would like to thank Medimaps for the opportunity to share with you the experience of using TBS in clinical practice. Antoine has been introduced, and but I must confess that my experience with the TBS started about 10 years ago. I combined myself, and I was also able to combine my bosses because we tested TBS on approximately 1,000 patients, mostly women. It behaved similarly to the Canadian population study in Manitoba. Although the characteristics that impact me the most was that in the group of women with vertebral fracture, 96, in 9 of them, they had normal BMD values, but remarkably, in all of these women, independently of bone mineral density, the TBS was significantly degraded. There is a general concern in the medical community not to increase the health costs related to diagnosis of and treatment. But the truth is that osteoporosis and other fragile osteopathies remain under diagnosis. Since the World Health Organization technical report in 1994, the recommended technique for diagnostic osteoporosis remain DSA, the dual energy read absorptiometry. The main reason and bone mineral density is a variable closely related to the bone strength. bone mineral density is a good predictor of fracture, but the measurement offers information on integrated bone, trabecular and cortical bone together. And in clinical practice, we found partial overlap in patients with and without fracture. But a situation of bone fragility are not justified only by bone mineral density. It also influences on bone strength, the bone turnover, the mineralization of the bone matrix, and the macro and microarchitecture. We know that the diagnostic threshold for osteoporosis is to have a T-score minor of 2.5. Does not identify all patients with symptomatic osteoporosis. More of 50% of osteoporotic fracture occur in the normal or osteopenic zone. However, two types of patients can converge in this area. Some with a low bone mineral density with preserved structure and therefore with a lower risk of fracture, and other in which a degradation of the structure is added and consequently more prone to suffer fracture. But from my personal point of view, remain different question about the Trabecular Bone Score that I would like to share with you. This question and many other caused me concern when evaluating whether I should recommend the application of this new technique. This new parameter, the TBS, is determined by the analysis of the gray levels of DHA image. Specifically, the exploration of lumbar spine in a posterior anterior projection is based on the exploration of the experimental variograms of two-dimensional image. The TBS measures the level of gray of each pixel and compare the value to the neighbor cells, raising the differences squared. In this picture, we can make the calculation of bone mineral density. The algorithms make the calculation of bone mineral content in each pixel and added all these values in the all pixels identified as belonging to the explored bone, which lights with bony edges. In this other picture, we can understand how the TBS is calculated. The TBS algorithms explore the spatial variability of the pixel's brightness in the image, subtract the brightness from neighboring pixel, and square the differences. One of the main characteristics of the TBS is the relationship with microarchitecture. The image texture analysis don't measure bone mineral density. Rather, it reports on the structure of the trabecular bone. In this sense, TBS is related to the microarchitecture parameter as trabecular spacing, trabecular number, and connectivity density, and also are related with the structure model index and the bone stiffness. The question is the ability to predict osteoporotic fracture, one of the most important things. In this large study, performed in Manitoba in Canada, TBS confirmed the ability to predict any type of osteoporotic fracture, even after adjusting for age, bone mass index, bone mineral density, and other clinical risk factor, and therefore is an independent parameter of bone mineral density. In the graph of the study on the female population carried out in Manitoba, the women classified as osteopenic according to the bone mineral density measurement, and with TBAs in the lowest tertile presented more fracture than the osteoporotic ones with the highest TBAs. In this other study performed with a Japanese female population, the incidence rate of vertebral fracture in group of patients stratified by bone mineral density intertiles, normal, osteopenic, or osteoporotic, with a similar bone mineral density, fracture risk increased when TBAs decreased. The combination of bone mineral density, TBAs, and age significantly improve the diagnostic performance. I take this classical classification of the Manitoba population that we can see the more important performance of the TBAs. Probably one of the most remarkable capabilities of this technique is to complement the BMD in the classification of the population. Practically, the TBAs allows to reclassify 30% of the women classified as in the osteopenia zone. This is in each group. We can see that in the normal zone, using only bone mineral density, after TBAs, we can reclassify the 21% of people. And in the osteopenia zone, the technique allows to classify almost the 30%. In the osteoporotic zone, we take care with 5% of patients taken with a large fracture risk, but with a minor real fracture risk that we think. The other question is useful the TBAs in secondary osteoporosis? Although the Dr. Paul, after we review different cohorts with different pathologies, I make a brief review of this question. TBS and secondary osteoporosis. TBS has been shown to be particularly useful in various pathological conditions. It provides information on the structural impact of trabecular bone independently of bone mineral density, especially in diabetes, glucocorticoid therapies, primary hyperparathyroidism, patients suffering HIV infection, renal failure, and TBS is all decreased, also in ankylosing spondylitis and thalassemia major. But taking care of diabetes, one is more important than other pathological condition due to this is more sensitive than bone mineral density with a fracture risk. In a retrospective study on a large cohort of women in whom the 8% suffered from the diabetes type 2, the average of TBAs on this group has a lower value than the bone mineral density, both in lumbar spine and in the femur. All other characteristics in diabetes is that TBS is lower than bone mineral density, and this characteristic is associated with a poor glycemic control. Abnormal microarchitecture may help explain the paradox of increased fracture risk in this pathology in subjects with higher bone mineral density in diabetes type 2. Another group of interest to patients who should receive a glucocorticoid treatment. TBAs is more affected by glucocorticoid than BMD, even at a low doses as 5 milligrams milligrams per day, while no effect on bone mineral density are reported. The TBS, can it provide information to assess therapeutic efficacy? One of the agreed indications for bone mineral density measurement is patient monitoring and assessment of response to treatment. The ability of TBS to monitor changes in bone microstructure has also been evaluated. In this table, you can see the summary on the magnitude of the expected changes in the currently most used treatments in osteoporosis. PTH and denosumab usually produce an effect that we can measure easily with TBS, not so much with bisphosphonates or estrogens. This graph we can show that different therapies affect with bone mineral density and TBS in their magnitude. I take care to share with us our experience. This graph reflects the response to different treatment with bone mineral density and TBS. As you can see, the shaded area indicates the minimum significant level of change applied. Only patients treated with denosumab or PTH had a significant response. The fact that we hardly see changes in TBS in different bisphosphonates treatments should not be frustrating. This information expresses the way that the treatment works and that the impact on the microstructure is small. But how I can help the TBS in the clinical routine? There are other questions related with this main question, that the reference values are right for my population, or is important that diagnosis threshold could be different in different population, or how to combine BMD and TBS. And I try to show some examples. This is the line that show that is in our Spanish population, 3,000 women show the evolution with a life from the 20 years to almost the 90 years. This line show that the values in young women and men are very similar we can to see after when compared with the men. The TBS decrease with age in both sexes. The evolution allows in both sexes the adjustment of the 3 regression equations. If the maximum TBS values were detected in the 20-30 years decade. The decrease in TBS and bone mineral density is similar in the decade, the 40 and 50 years. When comparing with other population that show that in Europe, on North America, and the publisher for non-S Caucasian, Afro-American, or Hispanic, or also when comparing with published results from Latin America, we can see, and also with a Japanese woman, the reference group that has the greatest similarity in Spain with the maximum level reached of 40 years. And the inflation moment and the rate and amount of loss is more closely related with the non-S of Hispanic population in the United States. When comparing the men, we make the same exercise with non-Caucasian, Afro-American, with Latino American, and the Latin American different countries. We can add all the curves, and the age evolution curve of the TBS in Spain are similar to those observed in other populations. The women lost between the 20 to 80 years loss after 18% of the TBS values, and the men lost in the same age range the 14%. The diagnostic criteria that used was also a motive of a study for our society. We explore a cohort 9,000 patients. We perform tests in lumbar spine and proximal femur. We perform also the TBS calculation and take on this information the clinical risk factor in this population. We came to divide in tertiles, and we came to show, observe that the TBS threshold were very similar to the first offered for Medimaps, after calculated for the Sheffield University group team, and the SEIOM thresholds. We try to we explore a graphical format to combine the T-score of the bone mineral density measurement, lowest in the spine and femur, with the TBS measurement. We verified that it was intuitive to recognize the situation of combined severity of bone mineral density with TBS, and that it allows minimizing the situation of osteoporotic patients classified with normal bone mineral density. The points reflect that the values of 111 subjects of both genders with vertebral fracture. If we observe in the World Health Organization classification graph, we can make the bone mineral density, several of them, into overlapping of the normal and osteopenic zone. But when use this special graph that combine the T-score from bone mineral density and from TBS, are a different situation, different, more easily comprised, and there are not any case in the normal zone. Other capability is very important, is to have the inclusion of the TBS and adjustment variable of the FRAX for the assessment of the absolute risk fracture. I take this screen, the Spanish equation, with around adjusted with the TBS. I make an example, sorry. In this example, from a real case, a 60-year-old Spanish woman whose characteristic and T-score of the neck of the femur provide a risk of a major osteoporotic fracture of 7.5% of fracture, and fracture of the femur for 2.5 when integrating the value of TBS, in this case at the graded TBS. The risk of major osteoporotic fracture increased to 12, and the hip fracture to 4.8. That is very significant increase. I can to show with different examples of people that suffered different conditions or artifacts in DSA that influence the bone mineral density and don't affect practically to the TBS. This is a patient that can see the aortic, abdominal aortic calcification. We can see also vertebral fracture and very severe chronic degenerative process in the lumbar spine. We can view what is the level of BMD in the osteopenic level. This patient really is as an osteoporotic woman. And when to perform the TBS, we can see the value are practically out of the graphic. It's a very, very degraded level. Other example is this patient that we can make the exploration of the lumbar spine, and we can take in that we can see in the lateral L1 with image of fracture, concavity deformation, and we can be that even avoiding this fracture vertebra, taking only L2 with L4, we have this kind of osteopenic zone. And we perform the TBS. Well, this is a very degraded with a very, very low value. The risk of fracture with this TBS level is 9 times higher than for a patient with a normal TBS. Usually we make the samples that the interpretation we have and coincident values. That is the normal bone mineral density and a normal and also normal TBS results. And in this graph, we can see the both T-score in the normal zone. But usually also we make this kind of findings. People that has normal bone mineral density with a degraded TBS. This kind of nomogram calculate the T-score for the absolute value of TBS, and we can review with the different form to make this clinical classification. With our society taking all of this scientific evidence and making and inspired for the Manitoba population study, we designed these algorithms of taking decision in which BMD and TBS are combined to help in clinical decision making in the management of the patient with suspected osteoporosis. If you consider it could be interesting, I can send this kind of information material. And also, one question is, what limitation does TBS have? A reliable TBS results depend on correct PA acquisition of the lumbar spine. Yes, obviously. But the limitation of this technique is associated with anesthesia of those soft tissues in the abdomen, which behave like noise in the image and reduce the quality and reliability of the measurements. The software has algorithm for adjusting for the abdominal thickness, but should be cautioned in patients who have increased their weight by more of 85 kilograms. Oh, sorry. In summary, bone mineral density and TBS provide, sorry. Yes, better. Provide independent information on the state of the skeleton state. The TBS is obtained with the same standard spine scan with the same device, with the same time that the lumbar spine, with the same dosage of radiation. The combination of the both parameters, bone mineral density and TBS, allows for a better patient classification of bone mass status and trabecular bone microarchitecture. The TBS is less influenced than bone mineral density against the most common artifacts that affect DEXA measurement. Also, TBS allows patient monitoring on structural changes in secondary osteoporosis and impact of the chosen therapy. And thank you very much for your attention.
Thank you very much, Dr. Del Rio, for this great presentation. It was, I think, very useful, and now will be completed with Dr. Thomas Paul, who I invite now to speak and to, if you, Dr. Del Rio, if you can stop sharing your screen, we will also allow now Dr. Paul to make his own presentation. Dr. Paul, we don't hear you yet.
Audible?
Now we can.
Okay. Can I start?
Yes, please.
Yeah, thank you. Thank you, Medimaps, for this opportunity. In continuation with Professor Rio's talk, I will just going to briefly share what is our brief experience from Velo with a trabecular bone score. I will not go into a little bit of I won't go into basics. So this is my outline of my talk, and I will say from Indian context, prevalence of osteoporosis is about 40 to 50%. And when you look at the prevalence as the age advances, the prevalence also increases. And when we look at the DEXA, other than body composition, it is used for BMD, as well as vertebral fracture analysis, as well as hip structural analysis, or atypical fracture analysis, as well as this with additional software for trabecular bone score, which will tell us about the microarchitecture of the lumbar spine. Now, we all know that DEXA is a non-invasive method for diagnosis of osteoporosis. We do about 8,000 patients here every year for like DEXA scanning. And of course, as I mentioned, vertebral fracture analysis is the other application. We recently looked at our data of 400 postmenopausal women, and we found that we have a little high prevalence of about 1/3 of them having moderate to severe vertebral fractures. Coming to the TBS and fractures, in continuation with the previous speaker, whether this cutoff of 1.35, or when you say somebody has got a TBS score of less than or equal to 1.2, which means fully degraded bone, whether that cutoff is applicable to India, whether it translates into fracture risk, we need further prospective studies. Now, there are studies which are mentioned by the previous speaker, and which all mentioned about the odds for predicting TBS, predicting fragility fractures with an odd from 1.5 to 5 with a good area under the curve. Now, looking to our cohorts, I will be presenting as postmenopausal women as well as younger individuals, our utilization of DEXA in them. The first cohort, this is a study which we looked into rural women, 300 women, in fracture risk assessment tool without BMD, with the BMD, and with the BMD and TBS in predicting prevalent vertebral fractures. And we looked at the ROC, and we also looked at our cutoff for our rural women for major osteoporotic fracture, which was around 9 with a good sensitivity and specificity. All three, even when we incorporated Trabecular Bone Score, they had a good area under the curve and they predicted prevalent vertebral fractures. So this is our first study incorporating TBS into the FRAX. Now, does TBS assess bone evaluation in people with type 2 diabetes? So I have a case which who came to us last week, who's got a type 2 diabetes, 62-year lady on oral glucose lowering agents, presented with right fibula fragility fracture, managed conservatively. On examination, she had significant peripheral neuropathy and moderate non-proliferative diabetic retinopathy. Of course, her vision was okay. Labs showed suboptimal glycemic control. Bone mineral parameters, including renal function tests, were normal. When we did bone density, she did not fulfill the criteria for osteoporosis. But when we looked at the TBS, she had a fully degraded, that is 1.1. When we take a cutoff of less than 1.2, it means it indicates fully degraded bone disease. So it is indicating a microarchitectural damage. So this is a patient, no osteoporosis as per the BMD criteria, but TBS is showing low value on the background of diabetes of long duration. Now, this we looked into one cross-sectional study about 180 subjects with a mean age of 60 plus with diabetes duration of more than 10 years. What we found was osteoporosis at any site was seen only in 1/3 of the subjects. In our community studies, as I mentioned earlier, it was seen about 50%. Here in diabetic subjects, we found that osteoporosis at any site was seen only in 1/3 of them. When we looked at the low trabecular bone score with a cutoff of less than or equal to 1.2, about half of them had low trabecular bone score. So we found the proportion of subjects in diabetic with the diabetes had a low TBS compared to low T score for a diagnosis of osteoporosis. We also looked at prevalent vertebral fractures and self-reported fractures. About 37% had any fragility fractures. So next, we looked at the odds of TBS predicting any fragility fracture in this cohort of subjects with the diabetes. Odds was 5.5 when we looked with TBS in contradiction to bone mineral density, where the odds was 4.6. So there is enough literature to say that trabecular bone score is significantly affected in diabetic subjects. Of course, this Korean study quotes various postulate mechanisms, including accumulation of advanced glycogen end products, which affects the bone quality. But when we measure bone quantity by BMD, it may not be reflected. So this is the especially in subjects with type 2 diabetes. Now, what about the treatment on impact of treatment on trabecular bone score? This is we published last year in postmenopausal osteoporosis. When we give zoledronic acid, what happens to bone density as well as trabecular Bone Score. This is the first data from India, and we had at these subjects had at least 2 doses of zoledronic acid, yearly visit. At the end of 2 years, we wanted to see what happened to bone density as well as trabecular bone score. As you see in this graph, the bone density at lumbar spine significantly improved, whereas in femoral neck, it remains stable. When you look at the trabecular bone score in this group, they remained stable. There was no deterioration, adding to the fact that the anti-resorptive was useful and in Indian subjects. This is the first study where we looked at the trabecular bone score in postmenopausal osteoporosis. Now, coming to the younger age group, this is the study we published last year, looking in younger age group who are undergoing hematopoietic stem cell transplant for conditions like leukemia, lymphoma, and aplastic anemia. We wanted to see what happens to TBS and bone density. Is it when we compare them with age-matched controls, is it different? So we found that there was no difference with regards to lumbar spine BMD and TBS between cases and controls. Of course, the femoral neck BMD showed a significant decrease in cases, whereas this trabecular bone score walked in line with the lumbar spine BMD in patients who had undergone transplant. Now, the next cohort we studied is in primary hyperparathyroidism. We looked at this various bone mineral parameters, TBS, bone mineral density, and bone turnover in subjects who were diagnosed to have primary hyperparathyroidism, who had undergone curative parathyroidectomy, and we followed them up for 2 years. And we wanted to see every year what happened to these parameters. We found that there was a significant improvement BMD. Of course, in India, still we do see significant symptomatic bone disease in subjects who are presenting with the primary hyperparathyroidism. So the BMD significantly improved at 1 year and 2 years. When you looked at the trabecular bone score in men and women, we found that it was an upsurge, especially the first year, then it plateaued. But of course, we have only 2-year follow-up, so we have to get a further detail. So we found a trend of increase in trabecular bone score in 1 year, then it was little plateauing, though the BMD seemed to increase. So what about chronic liver disease? We know that at this point of time, we do see lots of cryptogenic cirrhosis and hepatitis B related chronic liver disease. Many of them with hepatitis B are on treatment for hepatitis B infection. We looked at a cohort of these 3 group, cryptogenic cirrhosis and hepatitis B group and controls. And we looked at the BMD as well as the trabecular bone score. We found that the trabecular bone score was significantly low in subjects with cryptogenic cirrhosis, whereas there was no difference between BMDs of these 3 groups. It may indicate that these subjects, the TBS decrease may indicate a microarchitectural deterioration even before a BMD decrement occurs. Of course, we didn't capture the fracture data in them. Now, this is another unique group where we looked at trabecular bone score. This is from the physical medicine and rehabilitation. They had a concern. Many of the young men following road traffic accident become paraplegic, and they are on a rehabilitation process for 1 or 2 years, during which they fracture spontaneously. So the research question was, what about the bone density and trabecular bone score? They noticed fractures in the femur, tibia, as well as spine. Now, what we found in this group of 43, when we matched with the controls, the bone lumbar spine BMD did not show a significant difference between cases and controls. Of course, trabecular bone score was significantly low in cases when compared to controls. However, the femoral leg BMD showed a significant decrease in cases compared to controls. We all note here in this table, forearm BMD was very good in cases when compared to controls, which was a surprising finding for us because we postulated they'll be using upper arm more than because they are paralyzed and they are not able to use the lower limbs. So this is another case where we found the trabecular bone score was significantly low in these cases compared to control subjects where the lumbar spine BMD was not significantly different. So I like to conclude, may not be a standalone tool, but complements definitely BMD and clinical utility of TBS may predict fractures even when BMD doesn't show osteoporosis. Yes, monitoring treatment, as a previous speaker pointed out, may improve at a slower rate, but it shows a different category of improvement for various agents. And with relation to bisphosphonate treatment may not predict fracture reduction, but TBS may be a very good tool to complement BMD, especially in subjects with the type 2 diabetes, primary hyperparathyroidism, paraplegia, and osteoporosis secondary to glucocorticoid. I like to once again thank the Medimaps for this opportunity. Thank you very much.
Thank you so much, Dr. Thomas. It was a great pleasure to see all these studies from you. We have quite a few questions from the attendees. There are different type of questions. We have some questions on patient's profile, cutoff values in primary or secondary osteoporosis. So my attempt now, I will ask you some of these questions. We'll try to make as many as possible. And to the attendees, what I will offer you is we'll again try to make as many as possible, but we'll take all these questions, and for the ones we cannot answer today, keep them and try to get back to you. You can also contact us, and I can direct your questions directly to the speakers today. I will be pleased to do that. So I will maybe start with one question. We can start with Dr. Del Rio. We have a question. We have a first question that's knowing the different treatments influences TBS differently. Can we use the combo of BMD and TBS to help choosing the treatment for a given patient?
Try. Okay. I try to. You can hear me?
Yes, we can, Doctor.
Okay. This question is very interesting. We work about this line, but obviously knowing if a low bone mineral density situation is associated with a degradation of the structure of the trabecular component can help to choose one therapy over another. Yes. If I have the PTH and denosumab that can help to increase the microarchitecture comparing with the biphosphonate, I would like to choose a more potent therapy in these cases. I have a slide, but it's not prepared. That with these algorithms, you can to change the combination of the low bone mineral density with degrade or not the TBS to select which is more proper therapy for these patients. But in this, I think that we need to work with more in deep in this line, because we can do to entry in a controversy field.
Okay. Dr. Dr. Paul, or also maybe Dr. Dario would have most experience in a chronic liver disease. What is your experience in TBS with this type of pathology, so chronic liver disease, to predict fragility fracture?
Yeah. So as I presented in my slide, patients with cryptogenic liver disease, where we looked at the trabecular bone score, we found that trabecular bone scores were definitely low in patients with this liver disease compared to controls. However, we didn't assess fractures, but having said that, it should be translated into fracture prediction. But from Indian context, there are so far no studies looked at whether the low TBS predicts fracture. I'm not sure about the international studies. Of course, I'll wait for Professor Ria to answer that also.
Okay, and Dr. Rio, do you also have experience in this pathology?
Not directly, but I have experience with co-workers of the clinic hospital in Barcelona, but their group of this hospital has a long number of people with chronic hepatic disease, and is taking advantage of the artifacts we can do. Some people of them suffer the ascites, the liquid accumulation, intra-abdominal liquid, and it's a problem to make evaluation of TBAs in these people with a very long quantity of liquid, intra-abdominal liquid, and we found problems with the TBS calculation depending on this abnormal liquid intra-abdominal liquid accumulation.
Okay, thank you.
As an artifact.
Sorry?
As an artifact, the trabecular bone, yes, is affected, but in the similar line of bone mineral density in this pathology. But additional, we have this problem in this kind of patient with hepatic cirrhosis as well.
Okay. Okay, thank you. Dr. Paul, in glucocorticoid-induced osteoporosis and post-menopausal women, BMD versus TBS, is there was one to choose?
I think when we look at the, especially the postmenopausal osteoporosis, the BMD definitely has got a more data. Of course, in glucocorticoid-induced osteoporosis, there are studies which just looked at the trabecular bone score, and they had an earlier deterioration, which was reflected by the low trabecular bone score compared to the controls. When somebody is on as low as prednisolone or equivalent of 5 milligram, they had an earlier deterioration of TBS compared to BMD. So in postmenopausal women, I may say it will complement rather than it's a primary modality for making therapeutic decision, trabecular bone score.
Okay, thank you. We have another one here. So in any patient who have BMD in the osteopenic range, but low TBS, without other CRF or vertebral fracture, can we start treatment based on TBS alone?
It's a good question. Well, actually, your question is very like somebody has got a low TBS and the BMD is in an osteopenic and we don't have any risk factor. So at this point of time, if impact of treatment based on low TBS without the additional risk factors in the presence of osteopenic BMD is, I'm not sure how much evidence is there, but I want to say somebody has got a low TBS and osteopenic BMD in conditions like diabetes, where you may have to consider treatment, especially when they have a diabetes associated complications like peripheral neuropathy or retinopathy. And I can ask, Professor Rio also to answer this question. What is his take on this?
Okay. Thank you, Dr. Paul. We have a question from a doctor who is orthopedics, and he was introduced, I imagine, to TBS before. Maybe Dr. Luis, you can help in that. So this doctor has been reluctant to consider TBS because most of his patients are post-fragility fracture. Therefore, he's not frequently struggling to make DX or difficultly to justify the investment in the software. Are there other applications that he should consider that would be useful for an orthopedic practice?
Very interesting questions. I think that TBS is a new frontier to explore. That not in the orthopedics, thinking only in the fracture and provide a very good new variable, but also in the young people and the pediatrics could be useful in order to consider when the bone mineral density is one variable, but other is the quality of bone. But I will need more time to answer this very important and interesting question.
Okay, I appreciate that. Dr. Paul, we know, especially in India, many orthopedists are used to manage osteoporosis. Do you have any feedback or comments?
Actually, I am also not sure what to, it's a very good question, but I'm not sure what, I can get back to you.
That's, of course.
Thank you.
Thank you. Maybe we can go with one or two more, and then, like I said, we will share all the rest of the questions with you later on the second step and get back to our attendees. We have a doctor asking that my patient, a gynecologist, has normal spine, femur, and forearm BMD, but low TBS. Should she be treated or not?
This is as I indicated in to the previous question. So we are talking about a patient who had a evaluation and found that normal BMD at 3 sites, but found to have a low TBS. I will look for additional risk factors like factors which can cause secondary osteoporosis. Then if they are there, I may use algorithm for like a fracture risk assessment tool. And if there is a risk, definitely in the context of this, I will start treatment. But per se, low TBS in the presence of a normal BMD without assessing other risk factors, I may not initiate treatment.
Okay. Thank you. Dr. Dario, would you recommend the same? Do you also have a same type of practice with we know there is not such values, cutoff values for TBS or guidelines that today states whether to treat or not to treat with a low TBS. And in fact, this question comes very often from many physicians, whether they should, regarding to BMD, which is sometimes with the osteopenia or even normal zone, and low TBS or medium TBS, what is your experience in deciding to treat or recommend to treat or not to treat?
I heaven responsibility in to take this clinical decision. But my role is only offer help to the people that has this decision. From my point of view, I know that it's not easy to answer this question. I think that I put other variable in to answer is the clinical, the common sense, the clinical judgment, but not only the bone mineral density, also the TBS, but also play a very important role, the clinical risk factor and the global circumstances that have this patient. There are many questions about how I can to take the decision. Sometimes out of the official guidelines offered for the scientific societies, could be out of line that to make to recommend a treatment in osteopenic patient, and in this patients we can to use the TBS as offer the support of this decision, not in the same sense. Not all the people that suffer osteoporosis, taking only in account the bone mineral density, we can do recommend a therapy, thinking in other very well health of these people, or they are not has a very good balance with neuromuscular equilibrium, or is people with very good health. Could be with a TBS, a normal TBS, or not degrade. We can to wait for the take this decision.
Okay, thank you so much.
It's a difficult balance.
There are many factors to take, and actually
yes,
many people ask these questions. We would like also to share questions from one of the doctors, Dr. Seaborn, which I know is assessing TBS in Australia and has some studies. And I will ask his questions to both of you. The ISCD recommends using TBS to adjust FRAX, assess the fracture risk. TBS significantly changes the FRAX percentage, most notably in younger subjects, or very little in those over 70. Would you care? How would you comment about this statement?
This is the incorporation of a TBS into fracture risk assessment tool significantly changes the prediction of fracture. Is it what the question
what
is?
would be your experience in the, how does it affect maybe with your local respective curves of FRAX? How do you see affecting your decisions on the treatments, or how does it help you in the number of patients for which it changes?
Yeah. So our recent study, which I mentioned in, we looked at incorporation of TBS as well as BMD into the prediction of any vertebral fractures. Adding TBS had like everything predicted well, like a BMD with and without TBS had a almost similar prediction for a prevalent fractures. So we don't have a data to say from our continent to see what happens at the end of prospective study. We don't have from Indian context looking at a FRAX incorporating TBS, but for a prevalent fractures, FRAX with BMD, FRAX plus BMD and TBS had a almost equal prediction or for the prevalent fractures. I just wait for Dr. Rio's experience from Spain.
Unfortunately, I don't use the FRAX in Spain, okay. Unfortunately, because fail the FRAX, the Spanish equation, to a proper recognizes the fracture, but not for the hip fracture in the all evaluation of the FRAX. The FRAX in Spain ran well for the hip fracture, but not for the major osteoporotic fracture. Only confirm the fracture in 30% of the people that fracture, don't run. If in Spain we use the Spanish equation, but some studies discovered it, but it's more proper to use the Swedish population equations in the north of Europe than okay. the Spanish. It's a problem with the relationship with the hip fracture and major osteoporotic fracture. There is not the Sheffield has not lack with the Spain case.
I see. Thank you to all of you for we have more questions. I will, like I said, I will summarize them. I will take all of them and make sure that we can address them. Thank you to our two speakers. Really warm thank you to you, Dr. Del Rio, for joining, and of course to you also, Dr. Paul, to have the honor to have you today. And it was very nice to you to participate. Thank you also to all attendees. I hope we were able to share the experience to give you more feedback on what TBS offers in terms of quality bone assessment, microarchitecture assessment, and how it helps within understanding bone health, managing patients and osteoporosis, as well as treatment. Thank you. We come to an end for these sessions. Medimaps will hold more in the future. We want to provide more webinars to the people who use TBS, who will use TBS in the future. So thank you all. And do you have anything else, Dr. Paul, Dr. Del Rio, you want to add before ending?
No, it was really a privilege, and I want to acknowledge my department staff. Is a strong team who could do the studies and help me. I thank you once again for Medimaps, for this opportunity. Thank you very much.
Thank you.
And also thank you very much for this occasion to share with the public our experience. Thank you very much also to Dr. Paul.
Yeah.
Thank you all, and you have a good rest of the day wherever you are in the world. Goodbye.
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 Goodbye at all.